The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome for the next episode of TMD Demystified. My name is Tony Urbanek. Today's episode is entitled The Integration of Dentistry and Medicine and TMD. I've touched on this topic before. I believe one other prior episode discussed it somewhat, but I'd like to take another look at it and discuss it today, because it is becoming much more popular and in the mainstream of dentistry to discuss how and why and under what circumstances dentistry should become integrated with medicine. So first, let's define our terms. So dentistry, historically, is a standalone profession that had to do with treatment of the structures within the oral cavity, primarily the teeth. And up until very recently, pretty much only the teeth and associated periodontal structures, alveolar bone, periodontal ligament, and related structures. And more recently, the profession has expanded its viewpoint into interest in other related structures, salivary glands, and most importantly, the concept that the oral cavity is the beginning of the alimentary canal, which prepares the food, not only just chewing, but salivary flow and the effect of salivation and saliva on preparing food for digestion. It all associated with the beginning of the alimentary canal, which is the oral cavity. And for that and other reasons, dentistry as a profession has taken another look at broadening the scope of the dental profession and broadening the scope of dental education to integrate it more with what is considered the profession of medicine. Now, medicine basically is the profession that deals with the diseases and symptoms associated with the rest of the body. So when you come to treating the body, you have two distinct professions. You have the medical profession, which basically deals with all other structures. I mean, that would include ophthalmology and ear, nose, and throat, otolaryngology, cardiology, the heart, pulmonology, the lungs, the surgeons who deal with musculoskeletal, orthopedic surgeons. You know, the medicine has all been broken up into specialties and subspecialties, but all under the umbrella of, quote, medicine. And dentistry, because of historical nature of education, has been segregated out as its own profession and limited to the teeth and related structures that I mentioned. Not necessarily for the benefit of the patient overall, because limited time in the educational process and because of expanding technology, both in medicine and especially in dentistry. The biggest thing, as probably much everybody knows, is that teeth now can be replaced with dental implants, which is a huge advancement over prior 1978, 1985, when the first dental implants came into view. But there is this growing interest and movement to integrate part, if not all, of dental education into medical education, and possibly even making dentistry a specialty or subspecialty of medicine, which actually, in my mind, and some would disagree and some would want to debate it with me, but makes logical sense. It takes a lot of time to educate a dentist to do what is traditionally called dental surgery, basically dental surgery on teeth, dental surgery, which then was expanded into periodontal surgery, surgery on the associated structures around the teeth, the bone, and the periodontal structures. And then, of course, with oral and maxillofacial surgery, now validly so, associated with the entire maxillo, upper jaw and lower jaw, facial surgical procedures, which would include orthognathic surgery, cosmetic facial surgery, which would include facelifts, rhinoplasties, cleft lip and cleft palate, cancer reconstructions, cancer ablation. Subspecialties within oral and maxillofacial surgery is now trained to do that, which rightfully should be the case, because actually the oral and maxillofacial surgeon, of which I am one, boarded, trained, with both dental and medical degree, is really our specialty revolves around the skeleton of the face, fixing, adjusting, treating trauma to the maxillofacial region. And of course, because trauma to the bone goes along with trauma to the soft tissue, we get very skilled at soft tissue reconstruction of one form or another. Obviously, at times competing with plastic surgeon and ENT surgeons, but rightfully so, each of those specialties has a part to play and can part to play depending on training with surgery on the face and associated structures. But the maxillofacial surgeon primarily has its interest in the skeleton of the face, and correctly so. We are the experts on the construction and reconstruction of the facial skeleton. Along with the facial skeleton comes the jaw joints, because the jaw joints are part of the facial skeleton. Basically, the oral and maxillofacial surgeon is the orthopedic surgeon of the face. Another way to describe it. And so when one speaks about the integration of dentistry and medicine and oral and maxillofacial surgery and surgeons as a specialty within dentistry, not medicine, although at least half of the oral and maxillofacial surgeons now also have a medical degree. So there's a lot of integration and overlap already. But in treating the body and treating patients, it really all boils down to who has the best training, who has the best training and spends the most effort on the science associated with doing the appropriate procedures and learning about that. But admittedly so, ENT surgeons, plastic surgeons, and oral and maxillofacial surgeons who, to some degree or another, can compete, but shouldn't necessarily so. It should be the specialty, the doctor himself, who has the best experience, the best knowledge in treating a particular circumstance or disease, which gets the best effect. That is a preliminary primer to what I would like to say about TMD and the integration of dentistry and medicine. Historically, TMD, temporomandibular joint disorder, was literally inappropriately given to the dentist as a problem to solve and treat, because the first article written, that to my knowledge, which describes symptoms of TMD, headache, earache, jaw pain, ear pain, was written by an ENT surgeon in St. Louis, Missouri in 1934, published in a journal in 1934 by a Dr. Costin, Costen, and that is why for the first 2 decades of the problem with this joint, the symptoms associated with this joint, the problem with this joint was called Costin syndrome. He wrote the first paper, and thereafter it was called Costin syndrome meaning associated symptoms in one particular problem. And the associated symptoms that he wrote about were primarily ear pain, jaw pain, pain extending into the head and the jaw, and even headache. Headache, earache, jaw pain, neck pain. Those are the 4 primary symptoms of Costin syndrome, which then led to temporomandibular joint disorder, which inappropriately is called by almost everyone TMJ, the name of the joint. Appropriate name is temporomandibular joint disorder, singular, not plural, because the disorder is only one disorder. And that was my discovery, that chronic inflammation within the temporomandibular joint creates all the symptoms. The symptoms are not created by too much motion of the jaw, although that's called bruxism. Too much clenching or grinding can cause muscles to get tired for sure, but that does not cause all of the symptoms. The symptoms related to TMD, temporomandibular joint disorder, singular, created by chronic inflammation within the temporomandibular joint, are now known to be and agreed upon to be by everyone. The symptoms of TMD are frequent and or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, feeling of fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are accepted symptoms of TMD. Now, those are very disparate symptoms. And what confused everyone, the dentists, physicians, and the patients for decades, were how can each of those symptoms be related to this joint in particular? And that's what it took me to figure out, basically. And it wasn't that hard when you know where to look and you had a little bit of knowledge about cell biology and gross anatomy, which is one of my trained areas, master's degree in cell biology and anatomy, besides dental and medical degree. Because I had the broad background and research background with 2 years of fellowship with the National Institute of Health, I took began an independent look at how in the heck this joint can create all of these disparate symptoms. And all of these symptoms in anyone's mind, in a patient's mind, must be associated with medicine and not dentistry. I mean, if you have upper back and shoulder pain, one would not necessarily be looking at this joint as the source. Obviously, if you have frequent or recurring headaches, one would not necessarily be looking at this joint to create those chronic and constant headaches. But as it works out, there is a mechanism that can be described easily and proven that chronic inflammation within this joint can actually create each and every one of those symptoms. And if you can decrease the inflammation, alleviate the inflammation within the joint, all of the symptoms disperse and go away, don't occur. That has been proven. So if you are talking about why and how, whether it's valid and appropriate to integrate dentistry and medicine, the study and treatment of TMD disorder, temporomandibular joint disorder, is the best example to confirm that there should be an integration of dentistry and medicine. This joint by itself and chronic inflammation, which is basically the study of cell biology, and gross anatomy, which is the study of the gross structures in any particular area of the body and how that relates to allowing inflammation to create each of those symptoms. That is what I've studied, that is what I've proven and can show and discussed in detail in other episodes how, exactly how, chronic inflammation in this joint can create headaches, earaches, jaw pain, neck pain, ringing, fullness, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and even exemplified in my most recent episode, last episode, of people having chest pain in the area of the pectoralis major and minor up here in the upper chest, thinking they're having a heart attack. How close could one be to perceiving that this must be a medical problem, and people going into the emergency department with terrible chest pain, thinking they're having a heart attack, when actually this chest pain is originating and created by inflammation within the temporomandibular joint. And I've discussed that in the last episode. Go back and read it. Read the blog and read the episode that talks about how you can get upper chest pain when you have inflammation in this joint. It's amazing stuff, but easily, as any anatomist or cell biologist would say, oh yeah, that's obvious how that happens. So the integration of dentistry and medicine can be and should be exemplified by what's going on within the temporomandibular joint. As dentists and dental schools, dental training and the dental profession expand the technology and expand the scope of dentists. Now, every dentist on every block wants to do dental implants. Every dentist on every block wants to do aligners for orthodontics. More orthodontics is done by general dentists now than is done by orthodontists, I believe. Of course, orthodontists want to do aligners. It's a new technology that works really well. Does not apply to everything, and I'm not here to talk about aligners and orthodontics. I'm not an expert on aligners and orthodontics, but I do know that is an expanded area, expanded technology that's very valid, as is the technology associated with treating this temporomandibular joint easily, non-surgically. I treated this joint surgically for 36 years until I decided the benefits and the success rate were not high enough. Yes, there were benefits. Yes, there were successes. But a third of the patients that I treated surgically would be back within a year or two with the same symptoms, no matter what kind of surgery I did on this joint, which led me to do the research and develop a non-surgical treatment for this that did nothing more than nothing less than relieve the inflammation within the joint. That is what this device does in protocol. It's a device in protocol that does nothing more than alleviate, decrease, take away inflammation within the joint. If inflammation causes all the symptoms, by decreasing inflammation in the joint, the symptoms go away. It's that simple. So it's a device in protocol, discussed elsewhere. I won't discuss that again. We're discussing the integration of dentistry and medicine, and why the treatment of TMD is the best example I can find, the best example I can think of, is how and why the education and the use of the dental profession should be integrated into medicine. As a trained dentist, I can tell you it takes a while to learn how to cut up a tooth and restore it. And it is very precise. And actually, it's very hard. It's a very hard profession to do. It's very hard on the dentist's body, leaning over a chair and working in such a small area, even though the technology has improved with lighting and instrumentation and high-speed drills. It's very hard on the dentist's body, and it's very hard to learn how to do that very precise. It's actually just as precise as brain surgery. It's just you're working on a tooth rather than inside the cranial cavity. Everybody thinks that brain surgery is so precise, and it is, and it's difficult surgery. But I can tell you, cutting up a tooth cutting into a tooth and preparing it for a filling or a crown or a bridge or putting in a dental implant is actually much more precise than a lot of surgical procedures on the brain. So, your brain surgeon, your neurosurgeon gets a lot of credit that may not be due, and the dentist doesn't get enough credit for the amount of spectacular difficulty surgery that he does when he's cutting on a tooth or doing periodontal surgery. So I just wanted to make the case of TMD and how it relates to the latest movement within the dental profession to integrate dentistry into medicine. I think it's valid. I think that there are pockets within the dental profession and within the newer aspects of how dentistry is delivered with the dental service organizations, one in particular, Pacific Dental, and its leader, its CEO, Dr. Thorne, make a special effort to actually integrate the facilities of dentistry and medicine, and are now integrating dental offices with convenient care clinics, which is a very interesting concept. I encourage it because my opinion, now everything next is my opinion, I think it's the correct thing to do. Dentistry should be integrated into medicine. It may take a little longer to educate a dental doctor to get a basic degree. Basic degree in dentistry is your DDS. Basic degree in medicine is your MD. But I think actually the dentistry should be a specialty, a subspecialty of medicine, and should be considered that way from patients and from the other professions because of its importance in the body structures generally. I mean, just consider how difficult it is for the body to function correctly if you cannot chew your food correctly, if you cannot chew your food at all, if you're trying to work with a denture, if you're trying to work with missing teeth, not to talk at all about the many different kinds of pains that are associated with decaying teeth, periodontal disease, and other structures that need to be addressed by the dentist and not as a standalone profession, but integrated with medicine itself. And temporomandibular joint disorder is the best example of identifying why that should be. With that being said, I made my point. I hope you agree with me. If you don't, I'd be happy to listen to your point of view if you'd like to do that. If you'd like to criticize what I have to say, I can be reached at tony@tmjservices.net, tony@tmjservices.net. If you'd like to learn more about how to use a device and protocol that actually solves the TMD dilemma and conundrum using a device and protocol that is extremely simple to use, extremely effective to use, very valid in developing within a dental practice, a dentist practice, and hopefully integrated within medicine. You can see more, learn more at www.urbanektmj.com. With that said, I look forward to next Tuesday when I produce the next episode and the next topic. I am Tony Urbanek, and this is TMD Demystified.